Good evening, everyone, and welcome to our medical gastroenterology GECO meeting. The meeting is hosted by GECO, by the Gastro Foundation in association with Project ECHO of the University of New Mexico. The GECO Fellows for Gastroenterology, the medical gastroenterology, is run every alternate week on a Monday night. It's starting at 6. The chat will be open for questions, and I encourage you to put your questions in during the talk so that we can just go straight into the questions. We do have participants from the rest of Africa, some countries in the rest of Africa, and we welcome them all very warmly. And with much further ado, let me introduce Dr. Muchichwa. And I believe he's from WITS, and he will take us through the functional upper GI tract tonight. It's all yours.
Right. Thank you for welcoming me, Dr. Fredericks. My name is Dr. Muchichwa. I will be presenting on disorders of the gut-brain interaction, the upper GIT tract, formerly known as functional upper GIT disorders. This is the outline of my talk. We'll start with some definitions, and then followed by the epidemiology, pathophysiology that entails these disorders, esophageal disorders. Then we'll come on to gastroduodenal disorders, and then lastly will be my references. Functional gastrointestinal disorders are a collection of conditions affecting every part of the GIT, and it shares most of the following features. The underlying pathophysiology and mechanisms is largely uncertain. There's no anatomic or traumatic defect that could cause the dysfunction per se, and there's no relation to metabolic abnormalities such as hypothyroidism. The symptoms are often vague and quite often difficult to localize. They are functional in that the normal neuromuscular junction of the affected part of the gastrointestinal tract is impaired and or causes discomfort. In terms of epidemiology, we found that it's actually common in females. In a study done by the Rome Foundation, found that, in about 26 countries, found that 49% of the women that responded reported at least one disorder of gut-brain interaction, compared to males that responded, which were 37%. In that same global internet survey, which had about 54,000 participants from 26 countries, as I said, about 43% of the respondents met the criteria. Also, in this type of patients, there's an increased risk of both atopic and autoimmune disease. So in cases where we are thinking of such diagnosis, we have to think of these conditions. There's a lot of inter-country variation and prevalence from that survey as well. And variability might reflect the contrast in genetics, cultural differences, the lifestyles, and dietary traditions that exist between the nations that participated. In terms of pathophysiology, it's actually a complex bidirectional dysregulation between the gut and the brain. We see from the diagram that I will present, there is a visceral hypersensitivity, abnormal gastrointestinal motility, and psychological disturbance have been recognized etiologies. There's low-grade intestinal inflammation, increased intestinal permeability, immune activation, and disturbances in the microbiome, have been identified as etiologies as of late. The central nervous system processing of the pain and other gut signals are required for the subjective patient symptom experience. There's abnormal brain activity associated with visceral hypersensitivity, as well as anxiety and depression in the patients with these disorders of gut-brain interactions. There are proposed models. About 50% of cases of these disorders begin with psychological distress, followed later by gastrointestinal systems. As you can see from the early lifestyle, genetic and environmental factors, the social support, the culture, the trauma, ethnicity at tender age, later on manifests in the pathophysiology, motility and sensation, the altered duodenal microbiome, the gut permeability and secretions later on. And then the outcomes of such disorders will then be quality of life, daily function and medication, and several hospital visits to general practitioners. Then in about 50% of cases in this gut dysfunction occurs first compared to the previous model, where then the psychological distress follows later. It is actually hypothesized that in genetically primed host, environmental factors induces the immune activation, the antigen presentation of the luminal antigen, such as the pathogen, food peptides, and T cells drives the maturation of naive T cells here, as depicted here, and then it leads to increased release of several cytokines that promotes activation and recruitment of eosinophils and mast cells. In addition to the traditional T helper pathways, as depicted here, we have also the secretion of interleukin-23 by antigen-presenting cells, such as these dendritic cells and B cells and macrophage, and promote the T helper cell differentiation. Ultimately, we have degranulation of mast cells, and also eosinophils then results in inflammatory mediators, which then damage the intestinal barriers, and also stimulates the damage of the enteric nervous systems, which then subsequently produces this hypersensitivity and motility disturbances, resulting in the GIT symptoms that we see. All these cascades, they can then lead to the stress and anxiety later on. And also, it depends now the extent, the site and the extent of this intestinal immune activation can then determine the phenotype, of the presentation. For example, proximal intestinal involvement might then give rise to the diagnosis of functional heartburn or functional dyspepsia, and then more distal involvement will then manifest in irritable bowel syndrome and functional constipation, and as well as functional diarrhea. In terms of diagnosis, it requires fulfilling of symptom-based criteria, which is the ROM4 criteria, and we need to exclude in a cost-effective manner other specific conditions with similar clinical presentations. Then we can then go on to esophageal disorders. Esophageal disorders, A1, we have functional chest pain, functional heartburn, reflux hypersensitivity, A4 globus, and functional dyspepsia. That will be the classification according to the ROM4 criteria. Then we can go now into detail with functional chest pain, defined as recurrent unexplained retrosternal chest pain of presumed esophageal origin, not explained on the basis of reflux or other mucosal or motor processes, representing pain different from heartburn, cardiology assessment, endoscopy and biopsies with pH, 24-hour pH impedance studies and esophageal manometry required. Functional esophageal disorders, in terms of criteria again for functional chest pain, the criteria must be fulfilled for the previous 3 months with symptoms onset at least 6 months prior to the diagnosis and a frequency of at least once a week. Retrosternal chest pain and discomfort, but must exclude cardiac causes. The absence of associated esophageal symptoms such as heartburn and dysphagia. Then the absence of gastroesophageal reflux and or eosinophilic esophagitis as the cause of symptoms. So an endoscopy with biopsies required of the esophagus. There must be absence of a major esophageal motor disorders as depicted on this diagram here, which would be achalasia, ineffective motility, absence, contractility, esophageal junction outflow obstruction, and the jackhammer esophagus. Next will be the functional chest pain. First et al. Estimated that within the non-cardiac chest pain cohorts, about 50 to 60% had gastroesophageal reflux disease, 15 to 18% had esophageal dysmotility, then 32 to 35% had actually true functional chest pain. In pathophysiology, as described earlier, there's hypersensitivity from the peripheral and the central sensitization, altered central processing and visceral stimuli, altered autonomic activity. Treatment in these cases, functional chest pain, basically with SSRI, tricyclic antidepressants form the basis of the treatment. Behavioral therapies are alternative and or complementary to medical therapies. Next will be functional heartburn, which is described as a retrosternal discomfort or pain refractory to anti-secretory therapies. Absence of evidence that gastroesophageal disease or eosinophilic esophagitis or esophageal motor disorder and histopathologic abnormalities have been excluded. Functional heartburn. So for patients, I mean, in this diagram, we try to ascertain which patients actually can be categorized to a group of the functional heartburn. And then there's also a group that will overlap with gastroesophageal reflux disease. So in patients that has got an endoscopy that is normal and biopsies that are normal, and they have an unproven gastroesophageal reflux disease before, and they are off PPI, they require pH monitoring with impedance. And if they are shown to have a normal acid exposure with no symptoms of reflux, these patients are then classified as having functional heartburn. For those that will have normal acid exposure and positive symptoms, will be classified as reflux hypersensitivity. However, for those with abnormal acid exposure, but with positive or negative symptoms associated with reflux, they will be classified as NAD. For those that had proven GAD before and they are on PPI, then they prove on to have more symptoms, but on pH impedance, they then have normal acid exposure with symptoms. They're classified as functional heartburn with GAD overlap. And then the ones that will then on PPI with pH impedance, they still have elevated acid exposure and they are known to have GERD before. They are then classified as having a refractory GERD. So that's how, in terms of trying to distinguish between these categories. Then reflux hypersensitivity, there's retrosternal symptoms, including heartburn and chest pain, normal endoscopy, and absence of evidence that eosinophilic esophagitis is the cause of the symptoms. Absence of major esophageal motor disorders, as described earlier. Evidence of triggering symptoms by reflux events despite normal acid exposure on pH or pH impedance monitoring. Pathophysiology and treatment is actually similar to those of the underlying functional chest pain and functional heartburn. There's actual evidence of upregulation of acid receptors, which is the TRPV1 receptors, also known as the capsaicin receptors or the vanilloid receptors. Psychological features are an important component of reflux hypersensitivity. Anti-secretory therapy may be of benefit than in any other functional esophageal disorders. Mainstay of treatment, as with the other esophageal disorders, it will be tricyclic and SSRIs. Next in the category is globus, which is an intermittent or persistent non-painful sensation of a lump or a foreign body in the throat with no structural lesion identified on physical examination, direct laryngoscopy, or endoscopy. Occurrence of the sensation occurs between the meals, and there's absence of dysphagia or odenophagia. The absence of gastric inlet patch in the proximal esophagus. There also should be an absence of evidence that the gastroesophageal reflux or eosinophilic esophagitis is the cause of these symptoms. And then absence of major esophageal motor disorders should be excluded. Global sensation may be a function of the perception of like a space occupying lesion or a manifestation of a typical manifestation of gastroesophageal reflux disease and associated with a gastric inlet patch and with potentially related to major motor disorders. Patients with globus, a diagnosis of a psychiatric diagnosis is prevalent. The mainstay of treatment and patients with globus rests with very good quality consultation with explanations and reassurance to the patients. There's anecdotal evidence supports the use of antidepressants as well as behavioral therapy. Next will be the functional dysphagia group, which is a sense of solid and or liquid sticking or lodging or passing abnormally through the esophagus. This group, we need the absence of or evidence that esophageal mucosa or structural abnormality is the cause of the symptoms. There should be absence or evidence, no evidence that the gastroesophageal reflux or eosinophilic esophagitis is the cause of the symptoms. We should also exclude major esophageal disorders. There's limited data supporting a higher likelihood of psychological distress in these patients with dysphagia. Treatment of functional dysphagia is usually supportive. It regresses over time. Reassurance and simple non-pharmacological measures is the cornerstone of this management. Also, supportive treatment includes eating in an upright position, avoiding foods that tend to precipitate the symptoms, and patients should be advised to have careful chewing of food, and also chasing the food with liquids may actually be suffice to treat the symptoms. Tricyclics antidepressants have been tried, but there is poor evidence to support their use in this group. Bougie dilatation, French 50 to 54, can be considered in patients with persistent symptoms. Next, we go to gastroduodenal disorders, which will be subdivided into B1, which will be functional dyspepsia, 1A, postprandial distress syndrome or epigastric pain syndrome. B2 will be belching disorders, which will be excessive supragastric and gastric belching. Then the vomiting syndromes, nausea and vomiting, the chronic nausea and vomiting syndromes, then cyclic vomiting syndromes, cannabinoid hyperemesis syndromes, and lastly, the rumination syndromes. We'll go through each and give a brief description. Functional dyspepsia is characterized by one or more symptoms, including the postprandial fullness, early satiety, epigastric pain, or epigastric burning, which are unexplained after routine clinical evaluation. Endoscopy and biopsies is actually recommended if patients have alarm symptoms. Alarm symptoms, to recap, will be vomiting, and anemia, patients with upper GI bleeding or lower GI bleeding, an abdominal mass, unintended weight loss, and dysphagia will include the patient that qualify, that will have alarm symptoms. Postprandial distress syndromes must include one of the following for at least 3 days per week. This is bothersome postprandial fullness impacting the usual activity, bothersome early satiation preventing finishing of a regular sized meal. Then the next category will be epigastric pain syndrome. This must include at least one of the following, at least 1 day per week. This is bothersome epigastric pain impacting the usual activity, and or bothersome epigastric pain burning impacting on usual activities. There should be no evidence of organic or systemic or metabolic disease. Supportive remarks: pain may be induced or relieved by ingestion of a meal or fasting. The postprandial epigastric bloating, belching, and nausea can also be present. Persistent vomiting likely suggests another disorder, and heartburn may coexist with patients with epigastric pain syndrome. Pathogenesis of dyspepsia, it's quite similar to the earlier slide, where we have the psychosocial model and then the gut issues, especially hypersensitivity to acid or wall distension, or even gastroesophageal reflux, gastric inflammation, duodenal inflammation, fundic accommodation issues, and abnormalities in the distribution of gastric contents, delayed emptying, abnormal myoelectrical activity, and overdistension of the antrum. So all these contribute to the development of this functional dyspepsia. Then evaluation and treatment of patients with functional dyspepsia, we have to, categorize them. If they have chronic symptoms, then we have postprandial distress symptoms. These patients, we offer them prokinetics. And there's patients with epigastric pain syndrome. We offer them anti-secretory therapy. Then you assess, is there adequate response? If there's adequate response, then you go into long-term management, prokinetics for postprandial distress syndromes, and anti-secretory for patients diagnosed to have epigastric pain syndrome. If there is no relief on either group, we offer antidepressants. And if there is adequate relief, then yes, we continue with long-term treatment, which then includes either anti-secretory with antidepressants for epigastric pain syndrome, or antidepressants with prokinetic for patients with postprandial distress syndrome. If there is no relief, then we refer these patients for further treatment or further evaluation, and offer them maybe dual therapies and or experimental treatment. When the patients have studied and they've noticed that they've delayed gastric emptying, we offer them antiemetic and prokinetic combination and then evaluate. If there is increased fundic tone, we offer them 5-HTA1 antagonist. If there is hypersensitivity from the assessment, offer an antidepressant and combinations. And then patients with duodenal mucosa inflammation and or increased permeability, we offer them Montelukast. These are trial medications. Next group in the gastroduodenal disorders are the belching disorders. The belching from the esophagus or stomach for more than 3 weeks, more than 3 days a week are required to make a diagnosis. Divided into two, B2A and B2B, for which there is excessive supragastric belching, which will be from the esophagus, or excessive gastric belching, which the contents will be coming down from the stomach. Supportive criteria for belching. Supragastric belching is supported by observing frequent and repetitive belching. Gastric belching usually has no established clinical correlate per se. However, objective intraluminal impedance measuring is required to distinguish supragastric belching from the gastric belching. Notably, from the impedance testing, you find that there is contraction of the stomach prior to the relaxation of the lower esophageal sphincter. Treatment of belching, supragastric, largely is reassurance. Speech therapy may actually offer treatment as well. And however, more studies are required to ascertain the role of speech therapy as well. Referral to a psychiatrist, as this often coexists with psychiatric illnesses. In terms of gastric belching, severe acute cases are quite uncommon, common in mentally disabled patients, and actually can result in diaphragmatic impingement and respiratory distress, for which, if this is recognized early, a session of NG tube can actually relieve the symptoms. Chronic cases of belching, advise the patients to eat slowly, avoid carbonated drinks. Speech therapy as well has got a role in treatment. Baclofen has been studied, and from its mechanism of action associated with decrease in both gastric and supragastric belching. Coming on to nausea and vomiting disorders, with the chronic nausea and vomiting syndrome, which is a bothersome nausea occurring at least once per day per week, and or one or more episodes of vomiting per week. Self-induced vomiting, eating disorders, regurgitation, rumination syndromes should be excluded to make this diagnosis. There should be no evidence of organic or systemic metabolic disorder. And then the 3B, which is the cyclic vomiting syndrome, it's defined as a stereotypical episode of vomiting with an acute onset and lasting less than 1 week, with absence of vomiting between the episodes. History is usually typical, but if histories are typical, an endoscopy or a CT brain to exclude an intracranial pathology and further porphyria studies should be considered in these patients. The next group will be the cannabinoid hyperemesis syndrome, which is a stereotypical episode of vomiting resembling the cyclic vomiting syndrome. In terms of onset and duration of frequency, it presents after a prolonged use of excessive cannabis. So history here is important. It's relieved, the relief of vomiting after the sustained cessation of cannabis use. Of note, patients, it may be associated with prolonged hot baths and showers. So in these patients, a history of such should be sought after. So patients with nausea and vomiting, we need to evaluate them quite closely. We need to consider other pathologies, gastroparesis, pseudo-obstruction, mechanical obstruction, metabolic issues, central nervous systems, and also consider rumination. Exclude acid-base abnormality at presentation because patients may have been vomiting for a while. An upper endoscopy and bowel imaging may be needed actually to evaluate the gastroduodenal disease and small bowel obstructions. CT brain, as I said earlier, it's quite necessary to exclude space-occupying lesion that may present with vomiting. And then we should also consider doing studies for gastric emptying. Esophageal pH testing to exclude a typical presentation of gastroesophageal reflux disease. In terms of treatment, 5-HT3 superior in terms of treatment for vomiting and for vomiting and not nausea. Supportive treatment is essential here. In terms of presentation, when they come in, let's not forget that they may be hypoglycemic and have electrolyte abnormalities that needs to be corrected. For cannabinoid use, hyperemesis syndromes, we need to send the patient for counseling. Withdrawal of marijuana actually does help. Last but not least, the rumination syndromes, this persistent or recurrent regurgitation of recently ingested food into the mouth with subsequent spitting and remastication and swallowing. The regurgitation is not preceded by retching. We have to note that. Then supportive information that may help in supporting the diagnosis of rumination syndrome is like an effortless regurgitation. Events are usually not preceded by nausea. Regurgitation is, often contains food that is recognizable and often have a pleasant taste. Once the taste becomes more acidic or non-pleasant food, regurgitation tends to subside. In terms of evaluation, we need a combined impedance and high resolution manometry that will show elevation of intragastric pressure before or concurrently with oral esophageal propulsion. Mainstay of treatment for rumination syndrome involves behavioral modification. PPIs can prolong rumination, however, it suppresses the heartburn and may protect the esophagus from the mucosa. So the use of PPI here, it has to be balanced. Baclofen, which blunts the lower esophageal sphincter, relaxation can be used. However, there's lack of data supporting its use. And data is insufficient for procedures, surgical procedures as such as Nissen fan duplication. Take-home message: these disorders, there is really no organic explanation for symptoms that can be elucidated, and there's bidirectional dysregulation of gut and brain interaction. Psychological comorbidities is common. Prompt identification and treatment is required. The symptom-based criteria, the ROM4 criteria should be used. Then with judicious use and limited investigations should be used. Treatment is actually based on the understanding of the actual diagnosis and the biopsychosocial circumstances that are available to a particular patient. These are where my references. And thank you.
Thank you, Dr. Muchichwa. There seemed to be one question in the chat. Let me just see. No, there's no question yet. So these are conditions that are fairly common and that we often don't discuss in the clinic, or not very frequently anyway. But it comes up in exams, and it's something that you know that you have to, as a medical gastroenterologist, that you have to have a fair grasp of understanding about. So, you know, it's going to be difficult to go through all of the various things, but I think that the important ones, I'll just pick out one or two things. And the first one I want to talk about is rumination syndrome. Rumination syndrome, obviously, I mean, you've defined it very well. You just, you know, when you will be asked, you need to just think about what is the possible differential diagnosis if you suspect rumination. So what are the other things that you have to keep in mind before you finally come to that sort of the diagnostic conclusion?
In these patients, we need to exclude gastric outlet obstruction. We need to exclude things. I mean, we need to actually ascertain the diagnosis properly according to the ROM4 and exclude other diagnosis as per se. Let's see.
Yeah, so what you really would like to exclude is gastroesophageal reflux disease, because I mean the symptoms are very similar, because it's regurgitation of food, but it can also be sometimes an acidic thing. So gastroesophageal reflux disease are far more common than rumination. So that's probably the one thing that you need to exclude first. The other is one of the eating disorders that we sometimes see in young patients, like bulimia. So they would present sometimes with this, and you know, and not because they don't often sort of have the wherewithal to explain to you exactly what they, you know, what they have, and it will be just, you know, regurgitation of food or bringing up of food. So those are the things that you have to be mindful of. What I would also like to know is, what would you think, what are the unintentional consequences of rumination? What are the other clinical things that one comes across in these particular patients?
We should be concerned about aspiration. We should also be concerned about rupture of the esophagus. Those will be the major ones.
So if you have rumination, what would you do? I mean, you know, this is an involuntary regurgitation of food. So what patients often do is they eat smaller meals. They eat smaller little bits and try and snack throughout the day. So often there is unintentional weight loss. So the patient may come with this and say, you know, but doctor, I've lost weight. And there's this concern that you will think maybe there's an alarm symptom, but don't be alarmed. So unintentional weight loss is one. And sometimes, you know, as it progresses on, sometimes they can have acid with it together with the food. So acid may well come up into the mouth. So they can have dental caries and dental things, yeah. And sometimes they complain of bad breath. So those are the sort of little caveat things you have to just be aware of and maybe inquire a little bit more in depth if you see patients like this. So I think there was one question in the chat. Let me just see what happened to this chat now. Oh, Sianda just wants to know how well do these syndromes respond to psychotherapy? Do you know?
So throughout my reading, psychotherapy was an independent form of treatment and can actually be used with the medical therapy, which is the tricyclic or SSRIs. In terms of the percentage response, I didn't come across any study that says particular 40 or 50 or 60% of the patients that get psychotherapy do respond to treatment.
Okay, I'm not sure that answers Sianda's question, but I mean, that's the answer. What I would like to, and the next important topic that I'd like to go to is functional dyspepsia, and you've given us the breakdown and you've given us an algorithm for treatment. But I would just like to pose this to you. If you have a 25-year-old that comes to you with dyspeptic symptoms, what would be your strategy? There's 25, there's no alarm features, he has dyspeptic symptoms. Now what now?
Right, yeah, after careful history and then exclusion of cardiac causes, which is unlikely in a 25-year-old, the first approach will be a trial of PPIs and see if this responds to PPIs. If it responds, then I'll presume that this patient has got gastroesophageal reflux disease. If
will you only give PPI therapy?
Pardon?
Will you only give PPI therapy?
In this it's PPI plus and psychosocial support. I mean, if I am going the dyspepsia route.
No. What is the role of H. pylori in functional dyspepsia?
There is a role in functional dyspepsia for H. pylori. It's actually associated with the pathogenesis.
Tell us more.
A certain subgroup of patients with H. pylori can be associated with functional dyspepsia, and then that subgroup can be determined if the patient is eradicated empirically, and then if there's a response, then you can then subclassify those groups if you haven't done an endoscopy to prove it.
Okay, so what are you going to do with a 25-year-old?
So then depends with the prevalence of H. pylori. Probably eradication, I'm not too sure there if I should eradicate empirically or just try PPI and then see if it works.
No, there's a test and treat strategy. What is the test and treat strategies? What does it suggest? What are you supposed to be doing with test and treat?
Okay, so you offer the patient PPI and eradication therapy, and then see if there's any response. If there's a response, then you classify this patient as a subgroup H. pylori associated.
So how would you test for H. pylori?
You can simple test, urea breath test, stool test, serology. In a 25-year-old,
which one will you use?
Pardon?
Which one will you use at WITS? Which one will you use at WITS? Or Baragwanath, or wherever you work. Which one will you use? What do you normally ask for?
The H. pylori serology, if you haven't offered this patient an endoscopy because there's no alarm symptoms.
How reliable is serology for active H. pylori infection?
It's not reliable because previous exposure serology may remain positive.
So why do you want to do that?
Pardon?
Why do you want to do that then?
In a history where a patient hasn't been treated and the patient has got dyspepsia, then it may be of value.
Okay, let me tell you. So you may do the stool antigen test, right? Okay, so how accurate is the stool antigen test? What is the sensitivity and the specificity of it? So if you've done the test and it comes back negative, what is the percentage of people that will have a negative test, although they have it? So what is the sensitivity and what is the specificity?
I'm not sure of exact figures there in terms of sensitivity and specificity of a stool antigen test.
Okay, so now you get a positive test and you eradicate, right? You give eradication therapy and then you review the patient again. So what is the benefit? What is the perceived benefit of H. pylori in eradication in functional dyspepsia? Is there a benefit, number one? If you eradicate people with dyspepsia, functional dyspepsia, do they get better?
H. pylori associated dyspepsia, they do get better.
How many of them? How many do you need to treat to have one good result?
I'm not sure there.
Okay.
Number to treat for, I'm not sure.
Okay. So Dr. Naidu wants to know, can you just clarify the role of endoscopy before diagnosing functional dyspepsia? Thought this was a requirement for most recent Rome criteria, even in the absence of traditional alarm symptoms.
The
role of endoscopy before diagnosing functional dyspepsia. Should everyone have a scope? Should your 25-year-old have a scope? Before, instead of test and treat, maybe just have a scope?
From the Rome criteria, we need to exclude gastroesophageal reflux disease, and also exclude eosinophilic esophagitis, which you can objectively exclude by doing biopsies. So in patients with alarm symptoms, yes, it's quite straightforward. In patients with no alarm symptoms, I'll still need to exclude, as per Rome criteria, things like EOE.
Okay. So the question is, will you scope everybody? Will you do gastroscope of everybody that comes to you with dyspepsia? Or only some?
Patients with alarm symptoms, yes, scope. Yeah. Patient with no alarm symptoms, test and treat first. In a resource-limited settings, test and treat first, and then if there is no improvement, then go on to endoscopy. Although that forms a deviation from the Rome 4 criteria.
Right. So the 25-year-old, you tested and you treated. You give PPI therapy for 2 or 3 months, and she comes back and she said, "Doctor, I am no better." What do you then do?
We can offer double the doses of PPIs and for a period of about 2 weeks and see if there's any improvement.
Remember, you haven't did a scope yet. You haven't scoped her yet.
Okay. Oh, in this patient, then we have to scope and see, exclude other diseases.
And if the scope is normal?
Biopsies are normal as well.
Yeah, everything is normal. Normal scope, normal stomach, normal histology. Then what? What do you do next?
Then we need to exclude things like reflux. So manometry and impedance, they could be of value.
But he has dyspeptic symptoms. She has dyspepsia. She doesn't have reflux-related symptoms. So she has mostly dyspepsia. How will you take it further?
Yeah, we can escalate PPIs, refer off to a psychologist at this point to see is there any other things that we're missing psychosocially. And then offer TCIs, tricyclics, or SSRIs.
Okay. How would this then be different if this is a 45-year-old? So we don't have a 25-year-old anymore. The patient is a 45-year-old. Would it change how you manage her?
Yes, it will change in terms of age-wise. I need to also start thinking of malignancies and then exclude that.
So 45 and older, you will do a scope first day. You see, and then you do a scope, and then you'll work out your algorithm from there. Okay. Are there any other questions from the floor or from the audience? We just have a reminder here that we have to give feedback about the session. And the web address is in there. The web link is in there. If you could use that, please. And if there are no other questions, then oh, Muchichwa wants to say something. Muchichwa, go ahead. Put on your video. Let me see you.
I don't have my face on. I don't have anything to say. I just wanted to use the opportunity to congratulate our newest gastroenterologists. Zamo and Thania. I'm impressed, Zamo, that you are still getting continuous medical education. Well done, you.
Thank you so much. It never stops.
Yeah, it never stops, for sure. But you guys have done very well, and we're very proud of you. And thanks for a great session. Thanks, Dr. Muchichwa, and you, Ernest.
Good.
That's all I have to say. Thank you.
Okay, thanks, Muchichwa. So if there are no further questions, and then I think we can just, yeah, first of all, maybe say congratulations to all the candidates that now are certified gastroenterologists. And I just want to thank Dr. Muchichwa for his insightful talk. And we also want to thank the ECHO UNM and ECHO India team for their support. The feedback, as I said, is available in the chat. Please use the link and give us feedback. It's very valuable, and it helps us plan future events. And this recording will be available on the Gastro Foundation website afterwards. And we also want to say thank you. Yes.
A raised hand from Sianda.
Oh, Sianda, you can speak.
Hi, Prof. Prof, before you leave us hanging, how would because we're none the wiser, so how would then the case change if the patient is 45 years old?
No, when a 45-year-old, you should do endoscopy as a first investigation. You don't have to do test and treat. So you will investigate immediately. So the 25-year-old, you can do your test and treat strategy, but the 45-year-old, you'll do endoscopy immediately. And depending on that, get your histology, get your H. pylori result, and then manage the algorithm further. Okay, clear?
Thank you.
Yeah, Prof. Thank you.
Bye, Ernest.
Hi, Nani. You want to say something?
No, nothing. Well done. Thank you.
Yeah.
Very controversial.
Very controversial.
Very controversial.
And for that reason, it's always in the exams, guys. Anyway, we also want to thank the Gastro Foundation. And finally, we want to say in 2 weeks' time, the topic will be nutrition, feeding, refeeding, the whole caboodle, and it will be Sianda Maslavsela that will be the talk, that will be the presenter at the day. And Dr. Noni Ramanathe will be the facilitator. Thank everyone very much, and have a great evening further.
Thanks. Bye.
Hi, Karen.
Thank you quickly.
Yeah. I think it went okay.
Yeah, it's fine. It's just that I can't get this feedback all the time. But we'll just leave it.
We'll chat soon. Thank you. Bye.
Bye.